Warning, this podcast contains violence, sexuality, gore, and other horrible and disturbing things. Listener discretion is advised. Also, the hosts of this venture are ignorant dipshits, so please do not take anything they say as fact. And enjoy the show.
Now, are you sitting comfortably? Good. Then we'll begin.
Today we had 15 homicides and 63 violent crimes, as if that's the way it's supposed to be.
It is our basic human right to be fuck-up.
A second plane now has crashed into the other tower of the World Trade Center.
Putting chemicals in the water that turn the friggin' frogs gay.
The defendant shall be incarcerated for the rest of her natural life with no possibility of parole.
You are not machines. You are not cattle. You are men.
We were somewhere around Barstow, on the edge of the desert, when the drugs began to take hold.
Oh, cultivary charges.
Hello, and welcome once again to a Culte Veritatis podcast. I am Ood Gallifrey, and in, not studio, but in distance recording with me, I have...
Sanctuary!
Adam Fowler.
Leon Vilger.
Richard Bigley.
And forever... Oh,
you're just gonna... Whatever, we'll figure this out one day that I can just say I'm the fucking soundboard demon and you can fuck off.
Yeah, that's true. I guess you don't need an intro. They know what you are.
They all know what I am.
I've been hearing you reaching your fingers out into the outer internet as well, so they're all going to learn who you are eventually.
Yes. Fingers.
Yeah. So today is an extra special episode. This episode was purchased through a donation to a charity auction for prairie harm reduction. You can tune back to our episodes on harm reduction if you want to hear more about that, but basically we offered up the chance to have anybody have us do any episode of their choosing, as long as they have the winning bid of this charity auction, and a friend of Adam's made that bid. And Adam, can you tell us the topic that you selected for us to cover today?
Sure, I chose palliative care. It's my specialty, and I just think it needs ongoing PR work, so that's why I opted for this one.
Yeah, it's going to be a sobering discussion of, that long walk into forever, so I think we need some poison.
So, what's your poison?
I guess long-time listeners of the podcast, I guess not that long, in our recent-ish history, you may remember us sacrificing Arthur Talus the Human in order to resurrect him as our soundboard demon. You know, we didn't want to go to college to become sound engineers, so it was the next best thing. We never really went through his belongings, and something was starting to smell in his room, but something we discovered when we went through there is this mead, this birthday mead. We don't know if it's good or not, but it exists, and we're going to put it in our bodies.
Arthur's Clover Birthday Mead. I'm looking at it. It's a mason jar. At least it's sealed, which is always a plus. You shouldn't necessarily drink things that aren't sealed. I don't know. It says that on the masking tape, Arthur's Clover Birthday Mead. So do you just drink it straight out of the jar? What's the recommendation? Or should I pour it into a glass? No,
just drink it straight out of the jar, dude.
Just drink it straight out of the jar. Okay.
The bottles say cider birthday mead, Clover birthday mead, bottled the 10th of December, 2018. So he must have been sitting on that for a while and then, got yoked to hell.
Did you say yote as in the past tense of yeet?
Yes.
That is correct.
That's amazing. I've never heard it used as an irregular
This is really
verb.
good.
Yeah, this is actually pretty good. It's quite liquory, like it's been fermenting for a while.
Very sweet.
Yeah, it smells really liquory. Like if you just smell it, it's like, oh, that's pretty liquory. But then when you taste it, it's really sweet and smooth.
Have you guys ever done the blackberry mead at Bushwhackers in Regina?
Not yet.
No.
No, that sounds good.
Should try that one day.
When you say a clover mead, is that because it's clover honey, or is it flavored like clover? Because I think that would just taste like grass.
I do believe it was Hutterite honey that was like a clover
yes,
field.
okay, that
like
makes a lot more sense.
Or whatever. Yeah, Arthur's dad got him this whole thing, and he was all excited because it was for his birthday. He got a big thing of honey, made some mead, and then, like I say, to hell.
Yes.
So.
How much of his memories do you have access to?
Oh, all of them. I can usually access pretty much anyone's memories, but it kind of hurts. But since I was a direct trade, I just have all of his memories. It's pretty lame. He was a sad human.
Lordy. I don't know, drinking this makes me miss an old tradition of mine, and that's drinking mead whenever I played D&D, because it just seemed to fit. And I think once I can play D&D in the flesh again, I might start again. Maybe even after boiling up my own mixture, trying that homebrew once again. I really like this. It's good.
Yeah, it's a good, I don't know, I'd go 9 out of 10. It's pretty good.
I'd rate this.
Yeah, I would go 9 out of 10 as well.
I rate this being at Divas, and after finishing peeing, a gentleman offers to wash and dry my genitals for me. And I'd never experienced that in the bathroom before.
Is this gentleman of your preferred gender?
I'm 50-50 bi, so all genders are good for me, and his gender was fine for me.
Okay, yeah, because I was going to say, yeah, if I'm sexually attracted to somebody, that obviously makes a different experience if they're washing my genitals than if they're not.
Super fair.
Whether it's all business or partially pleasure.
Exactly.
Yeah.
So I can't drink at 9 a.m. or I would fall asleep by noon, but I'm drinking, and I recommend this to you guys, Prince of Wales tea.
Ooh.
I just opened the Wikipedia episode and I didn't realize it goes back literally 100 years to 1921, but it's got some really subtle floral notes, and it is by far my favorite tea blend.
Prince of Wales tea. Okay, yeah. I'll have to put that on the to-do list.
And it never gets bitter because I'm bad for oversteeping tea in the sense that I just don't remove the tea from my teapot, but it never gets bitter, so it's very nice for that.
I'm adding that to my list.
Alrighty, let's move on to palliative care.
Palliative care is a kind of specialty care that helps optimize the quality of life for patients with a serious illness and their families. We have really focused on developing marvelous treatments and technologies to sustain life, to prolong life, and that's wonderful. But our treatments and technologies have gotten so advanced that sometimes we wind up using those technologies in situations where that's really not what's in the patient's best interest or what patients really want if they really understand all the things that are going on.
I had heard the word before, but I had always associated it with end-of-life decisions, which really made me anxious.
The most common misconception about palliative care is that it's the same as end-of-life care. And when we equate palliative care with end-of-life care, that misses enormous opportunities to improve care for patients with serious illness, either that we don't recognize who are dying or that may not be dying.
We believe that palliative care is about life. It's about enhancing the quality of life and enjoying life, even when you're dealing with serious illness.
There are two people that are on the mic right now that have a lot of experience in palliative care. I have none. As a layman, kind of come up with a list of questions I was wondering about and have two people with a lot of experience to answer and talk about them. So that's how we're gonna kind of do this episode, kind of a group discussion around this.
And I will say that although we're talking about sober discussions, I think most folks in palliative care do cope to an extent with humor because, sometimes if you don't laugh, you're going to cry.
Yeah. I mean, if you let every tragedy and sad moment weigh on you, if you're unable to make light of it sometimes, I can imagine it just that weight will just get heavier and heavier over time. Eh?
Yeah, a big part of...
Well, you sort of resign yourself to it, I think.
A big part of my job working as a care aide in palliative care is making self-deprecating death jokes in the middle of the night.
Oh, you have to, right? I mean, there's a pin that is for sale through somebody on Instagram that technically is meant for funeral directors, but I feel is very appropriate for palliative care, and it's a little coffin with a ribbon that just says last responder. Aww. And I love it every time. Yeah, I mean, I agree. I love the work I do. And I find a certain fascination with it. You don't end up in palliative care without being a little fascinated in that regard.
That's definitely the truth. And when I migrated into palliative care, I came straight from the funeral industry right into the palliative care unit in Saskatoon. So it was literally a just like one step back into life, into this career.
Definitely. I actually worked with a pathologist who had retrained into palliative care. And of course, pathologists do autopsies and things. And so the joke was that he's going to end his career as a obstetrician as he moves his way back up the life chain.
I'm going to read a definition of palliative care,
Please.
and the two people here can see if they want to, I guess, alter it. Like, there's many, many different definitions. This is just one of the ones I found. Palliative care is specialized medical care that focuses on providing patients relief from pain and other symptoms of a serious illness, no matter the diagnosis or stage of disease.
I would say the one word I would change would be, instead of serious, it should be life-limiting, in the sense that if you have something that can cause symptoms but isn't likely to kill you, it's not necessarily falling under our purview, if only for resource reasons. And I was going to talk about that a little bit later, but we only have so many doctors and so many beds. But certainly the scope is expanding in the last 60 years.
Yeah. Well, what about you, Leon? How do you define palliative care?
For me, palliative care is about enhancing quality of life. So it's like the two symptoms that we manage most frequently are pain and nausea. And so it's just easing the transition, I think, is the job of a palliative care worker.
And I actually did some reading a little bit later. We can talk about it, about sort of prevalence of symptoms. But I agree, pain and nausea definitely are the top two physical symptoms.
I also found some goals of palliative care. The first one is to improve physical, psychosocial, and spiritual symptoms associated with advanced disease. I guess, how do you see that first goal in your guys' line of work?
That captures a lot. And in fact, I guess this is jumping ahead a little bit to the services, but I think I have a bit of a spiel when I introduce myself to patients, because most of them are terrified of what I do and what I represent. And I say, hey, I'm a palliative care doctor. I know that's frightening. And I'll ask them what it means to them, because, if they've maybe had a loved one die under palliative care, they often have a bit of a better sense. But what I'll say is, I kind of wear three hats. I wear the one you're thinking of, which is that I take care of people who are about to die, right? And often I'll say, that's not you just yet. I might leave out the just yet, depending how cruel I feel that day. And then I say, I do a lot of symptom management, and that's usually our foot in the door. And so that's that first one, because usually they're feeling miserable, and that's why we're involved. And you really get a lot of cred by making them feel better. And then the last one is support at home and in the community. And that comes into physical support and emotional support. And if it's something they wish, helping them, say, die at home or stay at home as long as possible before we get them somewhere else, like a hospice or a hospital.
Yeah, patient-directed, right? And that kind of leads into the second goal that I found. Like, not only are you helping with making people feel better and helping them kind of die on their own terms, whether it be facilitating at home. What I read is part of the job is to help patients and loved ones through the stages of the illness. You kind of become somebody they can talk to and somebody that can guide people, loved ones surrounding the person that's in palliative care. Like, do you take on kind of like a mediator role or like a guider, like a guide for palliative care towards loved ones?
I can. We try not to, and obviously I'll let Leon, because he's at the bedside in a way I'm not. I certainly can. Hopefully we're not the sole mediator, because it's not our job, unfortunately, just to mend family problems. And I actually once remember I worked with a palliative doctor who's also a minister, and he was one of the more philosophical docs I've ever worked with. This is back in Ontario. And I remember once he said, Adam, if you see somebody who's got this really, either they're totally isolated or this really fraught relationship with family, he's like, it's easy to try to fix it, but for the most part, if you reach the end of your life and either you have no friends or family around you or there's constant chaos, usually these people are not, victims who have never partaken in that chaos themselves, and which makes it more difficult to fix, right? But certainly we can. And I also give advice around approaching death in different philosophical ways. And a palliative doctor named Ira Byock, if you're ever looking for books, and that's IRABYCOCK. He wrote a book called The Four Things That Matter Most. And it's sort of about finding closure in those relationships, things you can say or steps you should take. And it's quite a beautiful book. And I often bring that up to folks as we sort of process illness and process the end of relationships.
There are so many things that people have identified are often important. A chance to complete affairs, to complete one's business affairs, to turn over important projects, to give away things not before you die and within a will, but to give things away to people that you love or just value as a colleague, to make sure that projects are passed on off to, if you've been the chair of the annual fundraising event of the Rotary or your church or the chair of a committee at the bank, whatever, to pass that on so that you know that responsibility is well discharged. To say goodbye to people in not your intimates initially, but your colleagues or coworkers or the fellow you see, the guy who repairs your car, just to say, hey, thanks for being there all these years, and I may not be coming back because my health is pretty lousy. I don't think I'm going to be coming back with my car anymore. But thanks. I know we've had our differences in the past. It's been good to work with you, and if I don't see you again, thanks and bye. That sort of stuff people say they value. Deeper than that, in personal relationships of people who you love or once loved, again, a chance to say the things that would be left unsaid if any of you or the other person died suddenly. Have written a lot about the 4 things that matter most. It comes from stories that people have told me or that I've had the privilege of witnessing. Well, the things, of course, aren't things at all. They're just 4 sentences, 11 words. Please forgive me. I forgive you. Thank you. I love you. Please forgive me and I forgive you are often worth saying because, there's not been a perfect relationship in the history of our planet. Even the most close and loving relationships tend to be have some history of hurt feelings or misunderstandings. And sometimes real transgressions. So please forgive me, I forgive you. Thank you, and I love you are often like stating the obvious. In fact, of the people I'm thinking of, our intimates, our family, our close friends, those things really are stating the obvious. Usually, even if we're angry at a brother or a parent, we can also acknowledge on some level we love them. But for most of us, the love is more obvious. And, people say, I'll be counseling a family in an ICU and, the matriarch of the family has just had a stroke and can't speak and now has a fever. And we're having the discussion about, how long this should go on, about the trach and peg discussion. And after we get done talking about the medical issues and what to try and how long for this to go on and, getting through the substance of what she would want, what was in her advance directives, or if she doesn't have them, if she had them, what do you think she would have written? All of that. I'll often wonder aloud if it wouldn't be of value for them to say these 4 things to one another, that it's been, in my experience, helpful for others in the past. Not uncommonly, one of the children, usually it's an adult son, will say, "Oh, Mom knows how much we love her. She knows how much we appreciate all she's done, Doctor. You don't have to worry about that. Whether they're dying or not, if their life is at serious risk, maybe it would have value for you to say it. It doesn't hurt." And if I get response like, "Oh, she knows, Doctor, don't worry," my response to that is, well, good. Then it'll be really easy for you to get in there and say it. Because it's better said and even repeated than left unsaid.
Yeah, it must be hard to kind of find the line in between, like, stepping over the line of what, like, a therapist would do, or even stepping over the line of what like a lawyer may do in providing like legal guidance for next steps and stuff like that. Is it hard to like, I guess, know your boundaries and work and teach patients your boundaries in that regard?
I'd be interested in Leon's thoughts on this before I share mine, because like I say, you're in a much more physically intimate setting than I am.
Yeah, and when I was working in palliative full-time, I was on the night shift exclusively. And in a palliative care unit with small windows, the night becomes day and the day becomes night. And a lot of folks who are hopped up on Versed and Dilaudid wanted to talk in the middle of the night. And I was the guy they wanted to talk to. And I mean, aside from working as a family counselor in the funeral industry, that was sort of, the introduction I had to stages of grief, which I think are kind of largely bullshit. At least they don't work in a linear way. But for example, I had one patient, a man in his 50s who was dying of bladder cancer with multiple metastases. And he said, I need to talk. And I said, okay, I'm here to listen. And he said, don't tell my wife and don't tell my kids. Don't tell anyone, but I'm gay. And I had to tell someone before I died. And, we had protocols in place for when people confess to crimes on their deathbed. Like, if someone confesses to a murder just before they die, do we call the police? What's the protocol around that? So like talk therapy was a huge part of what I did. And I did a lot of it. I mean, like cleaning up people's bowel movements was a relatively small part of the job compared to what I do now in long-term care.
And that's been my experience. I don't want to be too crass about it, but to an extent, there are so many members of the team that it is almost an inefficient use of resources for the doctor to spend enormous amounts of time counseling when we have better trained counselors and social workers. Certainly, I've spent long time with patients sitting and talking and learning the meaning to their life and how I can support them as a physician, because I have a specialized set of skills that I try to stick to. When it comes to drawing boundaries, I'm a bit, I don't want to use the word heartless, but I feel like I am good at drawing strict boundaries, and it may just be my personality because I never struggled with it, but certainly when I have residents coming through, especially those who have never had experience with palliative care, that is something that's very important to teach, because you will otherwise just melt under, as you brought up, the emotional stress of it if you aren't able to distance yourself from those folks.
When we think about burnout, we often categorize it using some of the standardized scales into three kind of key areas: emotional exhaustion, depersonalization or cynicism, and then a sense of loss of professional fulfillment. And when we look across this survey, what we saw was that high levels of emotional exhaustion is prevalent at rates of almost 60% in the hospice and palliative medicine workforce. And that's inclusive of both physicians and non-physician professionals. When we look at issues around depersonalization, which is often the most dramatic of the effects of burnout, at least within the inventories, we see about 25% of healthcare professionals experiencing depersonalization, and that's similar in both groups. And if we look at the risk of having both the high emotional exhaustion or the depersonalization, it sits again somewhere in that 60 to 70% range. That's pretty remarkable. And one way to put that into context is actually to look at it as it compares to other medical subspecialties. So if you ask your hospital administrators, what's the highest risk subspecialty in healthcare, they'll tell you emergency medicine for problems around burnout and leaving the workforce. And we usually anticipate that's somewhere around 50% of emergency medicine professionals. So think about the data that we just saw for hospice and palliative medicine. We're talking somewhere around 60%, putting hospice and palliative medicine at very high risk.
Well, that sounds really important to be able to ensure that you help mitigate like doctor burnout and stuff, right?
Well, definitely.
Because if you're trying to be everything and doing all these different roles, then you're going to be a shit doctor.
Yeah, and actually a story on that is that when I was training, in the Christmas Day, so I didn't go home for Christmas for the first year ever. And I had a patient who was nearly my age, just a few years older, so a young guy. And he and I really clicked. And I remember I worked Christmas Day, and then I went back in on a day I wasn't working to speak with him and just sort of spend some time. And I actually got sat down by my bosses, my supervisors, and said, this is natural to your desire to do this, but for your mental health, you can't be doing this. You need to draw those boundaries and take your days off as days off rather than continuing to emotionally involve yourself with patients. And I think that was very good advice.
I'm interested in learning more about, what to do if somebody confesses to a crime or something while on their deathbed.
And that's a good question. I've never actually had that. I've certainly had people who had in past committed crimes, but were recognized and the legal side of that had been dealt with. Most often domestic abuse, because the partners will come forward to talk about that because it may affect their grieving or, their desire to care for that person, a number of things. To an extent, my instinct would be, depending on how close they are to the end of life, not to legally involve anybody because it won't make a difference. If this is somebody who has maybe years left to live, that's a very different story because we do have a duty to report.
Yeah, like in our case, we definitely had the duty to report, and it was specifically based on people, when I went through my bioethics training when I first became a care aide, we had talked about, what happens when someone says, hey, I buried a body at this location, you should send the police to go looking. Sure. And there was definitely the explanation that, no, we did have a duty to report. But at the same time, if someone is in the throes of delirium, very near death and completely high on Versed, is them talking to the police really going to benefit anyone? And I think the answer is usually no, but it was definitely a case-by-case basis. And deathbed confessionals of all sorts of things were a fairly regular part of my practice.
Mm-hmm. And I'm less commonly at the bedside to the same extent, both because I usually have heavier patient loads, but also that just isn't the same part of my job in this as a care aide or a nurse might have.
And the third goal of palliative care that I could find was to help determine a prognosis and plan for the future. So, you take a look at the patient and what the likely outcome will be, and I suppose try and form a reasonable plan surrounding. Am I correct on that?
100% from my end. Leon obviously would have seen some of this. What I often do, we'll sometimes literally just get consulted for prognosis, which isn't quite our job. But there is certainly evidence that the longer a physician knows a patient, the longer they are likely to predict that patient's prognosis will be, so they'll overestimate more. And I think that's the natural bias. So talking about logical fallacies coming up in another episode. But, if the longer they're alive, the longer your brain is going to be like, well, they've lived this long, so of course they're going to live longer. Where planning for the future is very much our goal. And in fact, with COVID, we just started a new line of a new physician line, where basically we are just going around and seeing all the sick COVID patients to clarify what they would want come, things going wrong.
These are hard conversations. I've blown them many times myself. I've not known what to do. And with this study coming out from the Mass General where the patients had seen a palliative care physician, I realized that the gain they'd gotten was that really they'd seen 6 people who knew how to, that's the staff at the Mass General for palliative care, that they'd seen one of these 6 people who knew how to talk to them about the end of life. And so what I did was I went to those doctors and just said, I'm really bad at this. If you had to make a little list for me of what it is that I should talk about with people facing these problems, what would you put on that list? One of the doctors that I spoke to was a palliative care physician at the Dana-Farber Cancer Institute named Susan Block. And Susan encapsulated it, I thought, the best for me, at least in a way that I could use. She said that there were 4 things that she has as a little mental list in her head that she wants to talk about with a patient who's terminally ill. Number 1, do they know their prognosis? Number 2, what are their fears about what is to come? Number 3, what are their goals? What would they like to do as time runs short? And 4th, what are the trade-offs they're willing to make? How much suffering are they willing to go through for the sake of the possibility of added time? That list was really interesting to me. It was not a list asking, do you want a ventilator or do you not want a ventilator as you come to the end? Do you want your heart shocked? Do you not want your heart shocked? Her point was, if you tell me the answers to those questions, I can make a recommendation to you that says, you would not want this toward the end if these are your goals. Our misconception is that the conversation is about hard choices. Really, it's a conversation about asking people about what they want to look forward to as time runs short and what they fear the most. And the second misconception is that that arriving at what we want at the end is a kind of epiphany. Sign here, do you want hospice, do you not want hospice? It's not an epiphany, it's a process. It's a series of conversations and ups and downs as we go through a very hard series of sequence of things that happen to you as you become ill and have things come to an end.
Yeah. So what kind of planning and prognosis do you do on your end? On your end, Leon?
What we did a lot of in the palliative care unit was having patients sent to us for a palliative consult. So they'd stick around with us for a couple of days. We'd try to manage their symptoms, like particularly pain and nausea. And once those were stabilized, we would send them back onto a unit or back into the community to their homes or off to, now we have a hospice, off to hospice.
And that's actually one of the more concrete parts of where my prognostication comes. So our hospice is sort of I hate describing it this way, but the expectation, quote unquote, would be that you would live less than 3 months. It isn't, somewhere you just go for 3 months. And so what we would do is get a sense, and there are all kinds of tools purely in the prognostic side that say, if they add up to this many points based on a number of factors, they have a 60% chance of living less than 6 weeks, or most likely will die within the next 6 months, whatever the tool is. And that does help us. Often we'll work with the oncologists or the cardiologists, whoever their life-limiting disease is, to work on that. But advanced care planning is really in our wheelhouse, and often, depending on this place we're working, we will get these consults for purely, hey, can you talk to these people and convince them that, this XYZ treatment isn't going to work, which isn't an ideal setting to meet palliative care, but at the same time, we do have more experience in those conversations than some physicians.
I think it's overall as a kindness, though, because if they don't come to reality about, how much time their loved one may have or how much time they have left, then they may waste time chasing dragons when no dragons exist. They have, limited time and they need to spend it as well as they can. And I think having a talk with them to be realistic about the situation at hand is important.
That said, though, there are going to be a certain number of patients and a certain number of families who will remain in denial until their last breath. I mean, I've had palliative patients certainly who are certain they're getting out of palliative and they're going to go walk back home and carry on with their lives, and that's not the case.
Oh, there's stories of COVID patients that die of COVID, and the last things they're uttering before the ventilator goes in is all about how it's still a hoax and this is something else, and the hospital's killing me and it's not COVID. And, yeah.
Certainly, and we ran into one just the other day at our hospital, or even just folks whose coping mechanism may be total denial. And sometimes you just can't, I hate to say, break through that, but it almost in some ways is a bit cruel to try to break somebody's coping mechanism if you don't think it will make a difference. And so, we've had folks where, for whatever reason, That's what they just could not accept that. But as long as their family came to some measure of understanding and, there were important conversations and, frankly, some important paperwork done, because if somebody dies without a will, for instance, that's a real headache. Stuff like that. But most of the time, folks come to understand it, or at minimum come to understand which treatments will or won't help them. And again, there are scales, for instance, for CPR. That's a classic one that indicate that, you'll have a less than 1% chance of recovering to the point with your existing level of neurological function. So your brain will be intact. Or you have a greater than 15% chance, which of course is a population that is going to benefit more from CPR. And having those conversations is very important.
So I'm going to list some of the services that palliative care could include, and the two people that work in palliative care here can add after I read through this list if they feel that there's services that you provide regularly as part of your job that isn't listed here. Assistance with the management of physical symptoms such as pain, shortness of breath, and fatigue. Assistance with the management of depression, grief, and anxiety. Emotional, psychological, and spiritual support for the patient. Counseling related to prognosis and decisions near the end of life. Assistance with advanced care planning such as living wills and the designation of decision makers. Assistance in the coordination of care with home care, extended care facilities, or hospice care, and grief counseling and bereavement support.
I would definitely like to add alternative therapies like music and art. I know at St. Paul's Palliative Care Unit, Ruth Eliason is our music therapist, and she's absolutely wonderful and comes in with her guitar every day. And music therapy is a huge part of how we do things on the palliative care unit. And there are other units and hospices that utilize art therapy or pet therapy or various recreation therapies. And I think those are important parts of palliative medicine.
And I strongly agree. And that's what makes, to me, certainly every area of medicine does do a team approach, of course, but palliative care tends to be a more integrated and large team. And I certainly agree. So some of this stuff would not just be from the physicians and nurses. It would involve social workers and trained counselors and volunteers. And as you say, all of these allied therapists. Everywhere I've worked has had good music therapists. We have pet therapy. We had, until recently, we had this beautiful French bulldog named Bluebell who just retired, who would come around and say hello to everybody and was just the sweetest. And I agree that goes a long way to make people feel more human, I guess, toward the end of their lives, which is what they are.
I'm going to go through some questions that I kind of came up with, and also some frequently asked questions that I found, and the two people here can answer them. So when is someone chosen to go into palliative care? Like, what's the line that's crossed when, I guess most experts would recommend they go into palliative care?
Yeah, and so it's not universal. You sort of defined it above. Well, you literally defined it above. That, it's these folks who have a life-limiting illness who may or may not have symptom needs, because as we were discussing, there's a lot of services that don't directly apply to quote-unquote symptoms. And so it's a life-limiting illness of any kind, whether that is cancer or organ failure or infection or trauma, assuming they're still alive, obviously. The standard definition is an expected prognosis of less than 1 year. And that's just because beyond that, prognosis is almost impossible. And so you would end up with a huge population of people who are very difficult to prognosticate, and therefore you end up with a very stretched set of resources. And palliative care is, although it does save money on the whole, it is still a fairly resource-intensive field. And of course, they have to agree to palliative care. And though we are closely involved in that, and that's part of my interest in the podcast, is to sort of broaden that involvement so that people recognize and benefit. Because the number of people I have cared for who go, oh, I wish I'd gotten you involved earlier, and the number of people personally in my life as well, is not insignificant.
Leon, what is your personal line that you would recommend somebody to go into palliative care?
I'm not the doctor making the decision, so I rely on the doctor and the patient shows up, and then we develop a care plan from there.
Yeah, and a couple of other things I guess I would comment is that, unfortunately, there are patients who are palliative by definition, but don't have access to palliative care for resource reasons or distance reasons or cultural reasons. You know, there will be physicians, both old and young, or nurses or whomever, who blockade that because of outdated ideas of what palliative care is. And, you know, we're obviously trying to expand that. And the numbers of people who have access in Canada is growing. I did find a number. Of course, numbers always lag, but there was a data collection between 2011 and 2016 that showed that the number who had access grew by 10 percentage points, so from 59% to 68% in that 5-year period, and I don't doubt that it's continuing to climb because there's an increasing recognition of the importance.
Yeah, so if somebody wants to die and is like in a remote community and wants to die according to their cultural practices, like you're saying that palliative care should be inclusive of those needs, correct? Yeah.
Definitely. And unfortunately, like everywhere else in the healthcare system, most of the doctors are, you know, white Europeans ethnicity. And so we're increasingly trying to learn more about both Indigenous and immigrant cultures so that we can support them in the way they view good deaths, but also to, you know, not over-medicalize deaths because of misunderstandings of what we can and can't do at the end of life to prolong life. Because there are certainly people, both, like I say, of European, but also other descents, who struggle with saying, well, let's not treat them to the very end because, as I say, of misunderstandings of what will or will not benefit their loved ones or themselves, depending on whom you're talking to.
How is a palliative care doctor's treatment different than a conventional doctor's treatment?
I mean, at the start, we're still doctors. You know, we still treat people, whether our skill set, we're certainly more specialized. And it's easy to sound like, you know, a naturopath or something by saying, well, what makes us different is that we care for the whole patient, because that is something you hear a lot. And that's not true. There are a lot of fantastic doctors who are not in palliative care who treat their patients like humans. I would like to say the majority. But one thing we have access to is a larger team. So what Leon said, and so that the big thing, of course, is that we focus on quality of life over quantity of life, and I think that's probably the greatest distinction. But as we'll talk about, it doesn't preclude treatments to prolong life, and we are funded in such a way that lets us spend more time with patients, which, I mean, works in that dignity therapy. And I'm not saying that other doctors don't care about their patients' dignity, but to an extent, allopathic medicine, so traditional Western, or sort of like standard Western medicine, of course, focuses on medical issues rather than dignity, sometimes necessarily. You know, putting a tube down somebody's throat to feed them because they need to be done that is not a very dignified procedure, but it may be necessary for life prolongation. But as we move away from that, the focus instead becomes treatments that preserve our patients' humanity because we are able to do that.
Yeah, because dignity in the time they have left may improve their quality of life and their happiness quite a bit before they go, you know?
I think my story of how I arrived at being a palliative care physician is probably one that resonates with other palliative care physicians, and that we experience a aha moment where something happens where we suddenly realize that this is an important area. In my training as a medical student, I received no training whatsoever in palliative care of the dying. And I remember when I did my rotating internship, I was allocated to a unit of about 8 beds in which ladies with advanced cancer were being cared for, cervix cancer, ovarian cancer. And it was a horrible experience. I remember we used to do rounds from the hallway. We were too scared, I think, coming close to the patients because we didn't know what to do. In hindsight, we felt on reflection, we felt so uncomfortable about that because no one had taught me how to do this. And the very first patient that I had as a physician to look after was a Portuguese immigrant, and my family background is Portuguese as well, who had metastatic prostate cancer. And he died a horrible death, severe pain. And we undertreated him horribly. And that memory stayed with me for a long time. And then when I came to Canada and I was working in a small town in rural Manitoba, on one particular day, a man in his mid-40s came to see me. And he couldn't sit down because of pain, and he had a very advanced rectal cancer. And he said to me, look, I've been to many doctors in this area, and I'm coming to you in desperation because I know I'm dying. I know I've got cancer that's spread throughout my body, but I can't live like this the last few weeks, months of my life. And I felt so uncomfortable. I remember vividly that moment sitting in front of him and going through my mind, through my memory, the memories of the Portuguese gentleman that I'd looked after and that unit that I'd worked in as an intern. And I ended up telling him that I couldn't increase his morphine because he'd become addicted, which is absolutely wrong. But I knew no better. And he started crying. He turned to his wife. He turned around, walked out of the room. And just before he left the room, he turned to me and he said, I hope one day doctors will be able to look after people like us. And that was my aha moment. And he walked out and I felt so disillusioned with my profession. I felt so helpless. I thought I'd let down a patient, but I'd also let down my profession. And the following day, I shared that story with someone, with a nurse. And that afternoon on my desk was a pamphlet on a course on palliative care, which was held at Hamilton. It was a week-long course. It was a fantastic experience. I walked out there feeling so empowered that there's so much we can do. I went back to the community and phoned up the patient. I said, look, could you please give me a second chance? I gave you the wrong advice before, but I know much better now. And he was gracious enough to say, sure. Here were needs that were being unaddressed. And as soon as I started connecting with him and started exploring who he was as a person and coming up with some ideas about, well, we can treat your pain, we can control your pain, and the relief on his face as the pain was reduced, and the comfort, and knowing that, look, you don't have to go through the last days and weeks of your life suffering with pain or other symptoms, that there is a lot we can do. I felt very empowered. I felt, well, we can do something here. And these are people that previously we were abandoning. So he lived another 3 months, and I cared for him in a small town in Manitoba. I was at his bedside when he died, and it was the most fulfilling experience I've ever had as a physician. And I decided there and then that this is something that I would like to do. And as part of that is to make sure that other physicians like myself learned and were trained on how to care for these patients, because we can make such a big difference.
What kind of illnesses do you commonly see put people in palliative care? I guess this is for either of you. What kind of things do you see?
Yeah. I'd be interested to know what you saw, Leon, before I sort of bring out some stats.
Metastasized cancer, breast mets, prostate mets, bowel mets, bladder mets, etc.
Certainly. And cancer is what really drew palliative care into the forefront. So palliative care is a specialty, as a true identified box specialty within the Western model, really only began to exist in the 1960s, and that was Dame Cicely Saunders, Dr. Saunders, in the UK, and she founded St. Christopher's Hospice in 67. But, of course it took place before then because people died before then. But unfortunately, death was sort of treated as the secondary issue, which is paradoxical because it was in the 60s and 70s that basically everything we think about as like medicine began to exist. So intensive care, most of the antibiotics we use, most of the surgeries we do, most of the chemotherapy agents, until the immunotherapy agents have developed in the 21st century. Was all in the 70s. So right as we were learning to cure people, we were also learning how to help them die better. So I looked up some stats for Canada. This is from the Canadian Society of Palliative Care Physicians, of course, which I'm a member. And so about 50% of those dying have cancer. And lung cancer kills more men and women than other cancers, which is why I tend to donate to lung cancer charities. In women, of course, breast cancer is sexy because it affects more young women and it affects breasts, and it, has the whole drama around it. But I'll get on my soapbox for a moment. The financial aspect of breast cancer, the marginal gains are dropping because there are so many treatments for breast cancer and people live so much longer, and it's wonderful to see. But I'd rather see my lung cancer patients live longer because that's still killing more women than breast cancer. In men, the second cancer is colon cancer, which is the third most common in women, and then prostate cancer in men. So you're seeing exactly what Leon said, that we're seeing a lot of these metastatic cancers. And then the second most common class are, of course, organ failure, whether that is the heart failure, COPD, so that's classically smokers' lung disease. Other things can cause it, kidney failure, and dementia, which is sort of brain cancer or brain failure. And then the rest are either acute events like strokes or brain injuries, neurodegenerative disorders. So the classic two are classic three are Parkinson's, multiple sclerosis, and ALS. And ALS is sort of Lou Gehrig's disease. And then less commonly, liver failure, although certainly I do see liver failure patients. And we don't have a good sense of how many COVID patients are being palliated, but certainly I've done my fair share.
What is the difference between palliative care and hospice care?
I mean, on my end, obviously they overlap a lot. Classically, palliative care is done in the acute setting, and it may come earlier and more classically aligns with life-prolonging treatment, where hospice care is more classically end-of-life care, whether it's happening at home or in a hospice or at a hospital, and it tends not to overlap at all with life-prolonging care. But the two are used a little more interchangeably. I think most people would kind of think I'm doing hospice care, even if I'm doing more what within medicine we would call acute palliative care.
Yeah, it's a bit of a heartbreaking discussion, but important to have. And we'll continue it next week, with Dr. Adam Fowler coming back. Sometimes people don't like to confront their mortality, and it leads to situations where they are unprepared for it. So here's my attempt to get people to confront their mortality. Hello there, person listening to this track. You are going to die. I don't know if you're 22 or 32 or in your 50s or 60s or 70s or maybe even a kid, but you will die. Your heart will stop functioning, your blood will stop pumping, and you will soon let go of the life that you held here. I can feel you. I can feel your mind pulling away from the thought, not wanting to focus on the thought that you may pass away, that your existence is not infinite, that your expiration date has been written on the stars already. You want to walk away from that fact. You don't want to confront it. You can't believe this thing, this unique experience that you had through your own lives, through your own feelings, through your own hands, could come to an end to be never again. You try and think about death. You picture darkness, like the kind that happens when the lights go out till you close your eyes, but no. Darkness is something that you experience. Darkness is something that we see and we react to. It's something that we interact with. In the end, there won't even be darkness. It's difficult to even imagine. Imagining oneself not existing is a challenge that has been mulled over by people contemplating their death and philosophers the same. How do you picture not existing? What is not existing even like? Your mind might recoil once it tries to imagine not existing. Once it tries to imagine a world where it doesn't even have a touch or influence, your mind rejects that thought. And because of that, it makes the more foolish assumption that this life will keep on going, this train will keep on moving, that life will continue forever. But it won't. Life is a fragile event. We exist. We are conceived of and born and live and die in short little periods. And your time will come as well. Whether you ever get to the point of accepting it or not, death will come for you anyway. Death does not discriminate, and the end will come for us all. We are a bag of mixing chemicals and emotions that accidentally came into fruition millions and millions of years ago. And billions have died since then. Life is fleeting and life is temporary, and that's part of what makes it worth living. Everything that is hot must cool. Everything that is in motion must slow. And everything that lives must one day die. And I want you to confront that fact. I want you to look at it straight in the eye. Because if you're not prepared for your own death, if you haven't done the things you want to do and prepare the things you want to prepare, and tell people that you love them, that you forgive them, you're stealing opportunities from yourself. Not only are you stealing your own ability to find closure and comfort in the life that you've lived, but from others as well. So in that spirit of acknowledging and confronting our own mortality, I'm going to say it one more time. And this time I want you to try and believe it. And then if you believe it, start to work on things you think you might need to work on before you go. Dear lady, dear gentleman, dear person listening to this recording, you are going to die, and there's nothing you can do to stop it. That's it. No after show this week. Because I think I've given you a lot to think about already. I love you all. Have a wonderful, wonderful night. And we'll see you at part 2 next week.